Hello, and welcome to the Fear and Avoidance Beliefs and Chronic Pain webinar with Dr. Robert Gatchel. This webinar is part of our chronic pain series, and we are glad to have you here today. My name is Mark White, and I'll be moderating the webinar today. I'm the CEO and President with the Canadian Institute for the Relief of Pain and Disability. And this webinar is made possible through the support of the Community Grants Program through the BC government, as well as through donations and memberships. As I mentioned, I'm Mark White and will be moderating the session and handling the Q&A session. And our speaker today is Dr. Robert Gatchel. Dr. Gatchel is a distinguished professor of the Department of Psychology, College of Science, as well as the Nancy P. and John G. Penson Endowed Professor of Clinical Health Psychology at the University of Texas at Arlington. He is the director of the Center for the Study of Health and Chronic Illness and a clinical professor at the Eugene McDermott Center for Pain Management, the Department of Anesthesiology and Pain Management at the University of Texas Southwestern Medical Center at Dallas. Dr. Gatchel has been a major advocate for the biopsychosocial approach to chronic pain. This approach is now viewed as the most heuristic model for better understanding the etiology, assessment, and treatment and prevention of chronic pain. Dr. Gatchel is also the scientific co-chair for our upcoming conference entitled Safe, Healthy, and Productive Workplaces, Learning from Research and Practice, which is being held in Vancouver, as well as other satellite locations in British Columbia, June 1st to 3rd, 2017. And we'll send information about that conference in case you're interested. Well, thank you, Dr. Gatchel, and we look forward to your presentation.
Thank you, Mark, and I'd like to thank everyone who is on this webinar. As Mark indicated, my major area of interest is chronic pain, and I've been doing this work for about 30 years now, and embracing a biopsychosocial model that is the interaction among biological factors, psychological factors, and social factors. And one of the important psychosocial factors that is very important in terms of evaluating patients and providing the tailored treatment for patients is what's known, the construct that's known as fear avoidance. And fear avoidance is one of those major constructs that many patients come in with. It's well established that patients with chronic pain often avoid activities that may exacerbate or increase their pain. This basic fear avoidance model proposes that if individuals are especially sensitive to the negative experience of pain, then this will result in a number of factors. That is pain-related fear of movement, and we all have had those experiences in our daily lives when we encounter pain. So, for example, if you pulled a muscle, then you might have some pain about using that muscle in some activity. And that might interfere with daily activities because you're afraid that the pain will increase or will come back if it's decreasing. And that in turn creates a lot of hypervigilance or over-monitoring of bodily sensations and potential increase in pain. Because in most instances, if you start to focus on a bodily sensation, you will experience it to a greater degree. And the whole point is to try to get the individual away from over vigilance or overly monitoring the bodily sensation. We can see this in everyday life. For example, if you have a child and the child falls and scrapes a knee and starts crying about the pain, okay, and focusing on the pain and looking at the pain, then he or she will continue to be concerned with the pain. But if you quickly pick up the child, okay, and don't make a fuss about a little scrape at that time, and distract the child and give the child, say, a piece of candy, the child's attention will be away from the pain onto something else. And as a result, the child will stop crying as much. Versus if you start indicating or asking, does it hurt, and try to bandage it and so on and so forth, it will increase the perception of the child and the reaction to the pain. So in a sense, they become hypervigilant to it. So these can in turn result in an adult, it's the same type of scenario. The adult or the worker will become hypervigilant and a little bit afraid of straining or maybe restraining a muscle or part of the body that is associated with pain, and this in turn can result in what we call physical deconditioning. And physical deconditioning occurs pretty quickly. If you stop using a muscle or a joint, the muscle will basically develop some atrophy, and the joint can also. So then the muscle that is surrounding the joint will be more conducive to further spraining and easier spraining. This then will create some additional psychosocial factors such as depression, because you start worrying about your inability to go to work or engage in recreational or family activities, and this then in turn starts that vicious cycle. And there's a lot of research that shows that fear avoidance is closely related to increased pain, physical disability, and long-term sick leave in chronic pain patients. So it's a major factor that one must consider. This whole concept was introduced very early in the 1980s by Lytham and colleagues, and they introduced it as the fear avoidance model of exaggerated pain perception, in order to explain how and why some people develop a chronic pain syndrome. At that time, chronic pain or pain that persisted, many times the medical community viewed it as the person might have some psychosocial factor involved in it. It's really not pain. Their perception is being affected by potentially psychiatric disorder, and a lot of times they would be referred to a psychiatrist to find out why they are suffering so much. But subsequently, with the biopsychosocial model, it became apparent that that viewpoint was overly simplistic. So people started to pay more attention to psychosocial factors such as fear avoidance in exacerbating and exaggerating pain. This model that subsequently was further developed and refined by a number of investigators like Asmundsen in the late 1900s. Valen and Linton are two major contributors to the model. They first presented one in 2000. And they basically outline the fact that there were two opposing behavior responses that could occur in response to pain. One was approach behavior. And the approach behavior occurs when there's an absence of any serious somatic pathology. Okay, so if there's not any major broken bone or major pathophysiology, it was better to then get right back and continue to engage in activities of daily living. And this was an adaptive response that would eventually lead to a reduction of fear and pain and promotion of recovery and physical functioning. In contrast, if the person started to worry about the pain, that the pain might come back, that is fear of pain, then that person would show avoidance behaviors that may be initially adaptive. That is, it basically may prevent the person from further straining or spraining a muscle. But if they went on to bed rest, that would lead to negative consequences such as physical deconditioning and then the maintenance or exacerbation of pain in the long run, resulting in disability. So the avoidance is something we want to, in a sense, avoid, the fear avoidance model. We don't want to avoid it. We want to approach it in a adaptive manner. Yeah, and this is this figure, the cognitive behavioral model of pain-related fear from Leyland and Linton. As you can see, if an injury occurs on the top, it will lead to a pain experience. Okay? So you sprain a muscle, a joint, or whatever, you'll experience the pain. Okay? When you experience the pain, there are two pathways. One, you basically, well, you've experienced that before, you recovered from it, so you assume you will recover from it again. So that will lead to the perception of no fear. And basically that will allow you to confront that initial injury-producing situation, albeit more carefully, and not get deconditioned, and that will lead to recovery. In contrast, if you have had in the past some negative experiences with pain, then when you experience the pain, you might get involved in a whole sequence of negative affective responses, such as pain catastrophizing. I'll talk about that in a little bit. Pain-related fear, you tend to avoid those situations for fear of hurting the muscle or the joint even more. And then you become hypervigilant, and then that will lead to disuse, disability, and then other psychosocial factors like depression, anxiety. You're worrying about what's going to happen if you can't go back to work, etc., etc. So this is very threatening information that will then allow the pain to persist and will even increase the actual pain experience, because we know that as we become more anxious, our pain threshold decreases. So we experience pain at a lower threshold. And so we get caught into this vicious cycle of pain, fear, pain, movement, and hypervigilance, where we will feel then the pain even greater because our pain threshold has decreased. And so we get caught in this vicious cycle. And it's that vicious cycle that we have to, as therapists, we have to break into as part of a more comprehensive program. Okay, in the next slide, there were a number of pain-related fear questionnaires because people started to realize that fear avoidance was a very important construct. So being a construct, we needed to measure it in some psychometrically sound way. And there were a number of instruments or questionnaires that were developed. For example, one of them was a Tamper scale for kinesiophobia, the TSK. So these are some of the questions in that questionnaire. For example, feelings of harm. I wouldn't have this much pain if there weren't something potentially dangerous going on in my body. We always hear that about the patients, especially those with low back pain, for example. They're afraid that, wow, I've broken my spine, or my spine has gotten fractured. They can't see their spine, but they just basically start to ruminate about that. My body is telling me I have something dangerously wrong with it. Well, pain is a very important sensation to have in terms of warning us that, or giving us an indication that we say, stepped on a nail, we twisted the wrong way. And so then the fear of harm, and then fear of re-injury. Okay, well, this injury has occurred, and now I'm afraid that I might injure myself accidentally and make it worse. And so I better not exercise because the exercise might exacerbate the pain. Then in terms of exercise, things like, well, it's not really safe for a person with a condition like mine to be physically active. My pain would probably be relieved if I were to exercise. Okay, this was a reverse score, or really if I did not exercise. And then avoidance of activity. If I were to try to overcome it, my pain would increase. Pain will let me know when to stop exercising so that I don't re-injure myself or injure myself. So those are some of the questions that are included in the TSK, which, as you can see, really are internal dialogues that most patients go through when they're experiencing pain. Okay, the next slide is pain-related fear questionnaires. The first is the what's called pain and impairment relationship scale. Questions are, an increase in pain is an indication that I should stop what I am doing until the pain decreases. I have to be careful not to do anything that might make my pain worse. I have come to accept that I am a disabled person due to my chronic pain. All of my problems would be solved if my pain would go away. So this evaluates whether a person has accepted that pain is going to remain, and has accepted the fact that in order to prevent the pain from becoming worse, they have to decrease their activities. Then another questionnaire was Fear Avoidance Beliefs questionnaire. This questionnaire was developed to differentiate fear avoidance beliefs about work, fear avoidance beliefs about physical activity. So my pain was caused by my work or by an accident at work. My work might harm my back. About physical activity, my pain was caused by physical activity. I cannot do physical activities which might make my pain worse. So again, this internal dialogue is going on in terms of the person ruminating about what might happen to worsen the pain if they engaged in any type of physical activity. And then the pain anxiety symptom scale, the PASS, it tries to differentiate different components of fear avoidance. Cognitive anxiety, I can't think straight when I'm in pain. During painful episodes, it's difficult for me to think of anything besides the pain. Then also escape avoidance types of cognitions, and actually then fear. I think that if my pain gets too severe, it will never decrease. And then physiological anxiety. I begin trembling when engaged in an activity that increases pain. Pain seems to cause my heart to pound or race. These are important pieces of information that you need to know as a clinician if you're treating a patient, because that will give you a map of what component do you need to concentrate on working with this particular patient. There's also a fear of pain questionnaire developed for children, because of course children experience pain also, sometimes more, and so this questionnaire was developed specifically for children. Okay, the next, we here at UT, University of Texas, we went a step further. We developed a new questionnaire called the Fear Avoidance Component Scale, or the FACS, because we felt we needed to develop a better all-encompassing set of constructs that would more effectively deal with critical issues, not comprehensively addressed in previous measures. Because again, the reason for developing these questionnaires is to aid the therapist in the best way of managing that patient. So, more importance now of disability and functional recovery. Those are questions that we ask in the questionnaire because those create a greater societal impact and cost of worker disability insurance. Secondary gain issues, work-related injuries or accidents in which another party is, quote, at fault. So, for example, if you think your the workplace was at fault and you slipped and you fell, then you might get on workers' compensation, or you might sue the workplace. And there's a lot of new research on the important role of victimization by an employer or injuring party. And that is, I'm a victim, the employer should have looked out after his or her employees more carefully, and they created the injury. And then the specific pain catastrophizing component is very important. Okay? As we go on to the next slide, we published this a few years ago because a lot of physical therapists were acutely aware of some of the verbalizations of patients, and they felt that there was a lot of catastrophizing going on about their pain. And you know, patients say, oh gosh, this is going to, you know, prevent me from ever working again. Very exaggerated types of cognitions or catastrophizing. So we wrote this article that describe what pain catastrophizing was and some ways of developing treatment for it, because we have subsequently found that people that have higher levels of pain catastrophizing are at higher risk for developing chronic pain and disability and chronic disability after an acute episode of pain. So pain catastrophizing is very important. And so we wrote this article to discuss what it was, how it might be evaluated, and how it could be managed by healthcare professionals. So it's an exaggerated negative orientation toward actual or anticipated pain experiences, basically a set of maladaptive beliefs. It plays an extremely important role in chronic pain and is associated with higher self-reported pain and disability. And it's believed to be a precursor of fear avoidance behaviors. So it seems as though this pain catastrophizing occurs first, and if it's not abated then, it will lead into more full-blown fear avoidance behaviors. And Sullivan was the investigator who first developed the pain catastrophizing scale. I should note that a special issue on pain catastrophizing, which I edited in the Journal of Applied Behavioral Research, will be coming out as a special issue in the first issue of JABR, Journal of Behavioral Research, and includes articles by experts in this area, like Haythorne Raitt, Bob Jamieson, Linton, we spoke about that, Shaw, who worked with Libya Mutual, Mick Sullivan, who developed the pain catastrophizing scale. So it's a really interesting series of articles that I would highly recommend you to read, because it basically reviews a lot of interesting new data in terms of, well, there might be even a genetic component for higher risk for pain catastrophizing. And pain catastrophizing can result in lots of different types of disability behaviors. So basically what we did in developing this was to look at items from the other questionnaires out there and look at the best ones that might be psychometrically sound and predictive. And so on this slide, you can look on the far left, on the left column, the fear avoidance components, okay, and how items on, say, previous questionnaires like the past in the middle column mimic that, and then the resulting facts item that we included in the facts. All right. So activity avoidance due to pain. So the item on the facts is, I try to avoid activities and movements that make my pain worse. Then activity avoidance due to pain-related fear. I don't attempt certain activities and movements because I am fearful that my pain will increase. Activity avoidance due to fear of injury or re-injury. I don't attempt certain activities because I am fearful that I will injure or re-injure myself. Okay, so these are the fear avoidance types of thoughts or cognitions a person has. And then we go on to other items on the facts. at the bottom of the figure in the someone else to blame, this taps into what I related before in terms of victimization. And that is from the Injustice Experience Questionnaire. I am suffering because of someone else's negligence. Okay, so basically they're projecting their problem on to somebody else. It was his or her fault. It is someone else's fault that I have this painful medical condition. And this occurs quite a bit. Most healthcare professionals, I've heard it. You know, if the workplace was safer, I never would have had to suffer through this. Okay, so it's a newer construct that we were able to incorporate into the facts. Okay, so these are there are others on this. I won't go through each of those, but the next slide will again provide some of the questions on the right that are in the facts. As you can see, it's easily understood. You just need a third grade reading level. We tried to be as straightforward and make the language understandable. And we found that there was good test-retest reliability and validity of it, of this questionnaire. Next slide. So again, some more. I think we can keep going with this to the next slide. As you can see, we're tapping into different activities: moderate, strenuous, light, full-time duties, recreation, exercise, because we wanted to see where the patient's fear avoidance is greatest in terms of activities and how they were avoiding those activities. Okay, next slide. This is, as you can see, this is the facts, the questionnaire itself, the scale itself, and patients answer each of the questions. Like, I try to avoid activities and movements that make my pain worse. And it's on a 6-point Likert scale from 0 to 5. We reverse items so that people will not get into a test mode where they always rate everything as a 5 without reading the question carefully and the alternatives. Okay, next slide. Then we this is a continuation of it. Okay, so there's 20 questions, total possible score of 100. Remember, there are 5 choices, so 5 times 20 is 100. We then did another study, again with the healthcare professionals in mind, is to develop cutoff scores in terms of responses to the facts. And this was accomplished by doing a study where we administered the facts to a group of, these are chronic pain patients who entered a comprehensive interdisciplinary pain program, which was a 3 to 4 week program. Okay. Then after that program, they were discharged. We administered the facts again. And then we basically follow them up for the next year. And at 1 year, we collected work-related outcomes, such as, did they get back to work? If they got back to work, were they still working? How much medication were they taking? Did they re-injure themselves? How many medical visits did they go to during that year in terms of health utilization? So some very important socioeconomic outcomes that basically will result in costs being high or low after 1 year. Obviously, if they had gone to a lot of physicians afterwards, that would drive up the cost. If they had surgery, obviously that would drive up the cost. If they were taking a lot of medications. So basically what we did was we looked at those 1 year socioeconomic variables, and then through some statistical analyses, we were able to determine whether they related to those 1 year outcomes. But before doing that, we were able to do a study where just in terms of self-report of pain, we were able to divide patients into those 5 categories on the scale. Subclinical, those were folks that scored from 0 to 20 on the facts, mild, 21 to 40, moderate, 41 to 60, severe, 61 to 80, extreme, 81 to 100. How did we develop those cutoffs? It was basically on face validity, as well as in terms of a scatter plot of where patients were scoring. These were sort of natural cutoff points where there was accumulation of patients scoring in those ranges. And then we took those cutoff severity scores, and that's when we then looked at 1 year outcomes. Okay, next slide. Okay, before getting into treatment, so what we found was those that came in with high scores on the facts, through treatment, a lot of them we could decrease their fact scores on. And that was part of the biopsychosocial component of our program, because we work with them, and I'll be talking about treatment in a moment, to get them more active using a functional restoration treatment approach. And so a lot of the patients, when we re-administered the facts at the end of the program, their fact scores decreased. Some did not. So then we used the end of treatment fact scores and see how they were related to 1 year outcomes. And as expected, we found that those that scored high on the facts, okay, in the severe ranges, they were the ones that were more disabled at 1 year and were using more healthcare dollars, i.e. they had more surgeries, they had more healthcare utilization, they had not gone back to work, they were seeing other specialists, and so on and so forth. All right? So the facts is a good instrument to use, okay, to find out where your patient stands in terms of fear avoidance, pain-related fear and avoidance. And then if you find that a patient is scoring high on the facts, then it's very important to treat it directly. Now, there's also other psychosocial factors that you might have to deal with in a functional restoration program driven by the biopsychosocial model, but pain-related fear is a major construct because you have to get these people moving again. And they have a high degree of fear. It really works against the physical rehabilitation or having the opportunity to rehabilitate these folks. So now a functional restoration program, we basically have them start reconditioning their models, because a lot of these patients are chronic pain patients. They had become couch potatoes. They were on lots of medications, and they were deconditioned. And they did not have the musculature to support their joints. And they then, when they tried to do something, they were more susceptible to strains and sprains. So functional restoration involves a very systematic reconditioning. Strength, range of motion, aerobic capacity, tasks required for involvement in tasks required to do the jobs that they will be getting back to get them ready. But obviously, a lot of patients, if they had a lot of fear avoidance, it was very difficult to get them to fully invest themselves into the functional restoration program. So there are those patients had to be treated with another component. And one component that Valen, and of course he is the person who first developed the major measure of fear avoidance, he and his colleagues, in one of our handbooks, in the third edition of Psychological Approaches to Pain Management, a Practitioner's Handbook, Dennis Turk and I have just finished the third edition, which will be coming out in a few months. I would highly recommend people that book. In Valen's chapter, he basically goes through graded exposure in vivo for pain-related fear. And that is how you get a person to gradually increase their exercise, okay, and decrease the pain-related fear. It's almost like what is called systematic desensitization in traditional clinical treatment. That is, you systematically expose them to higher and higher levels of movement or exercise, okay? But you do it gradually over time while they, at the same time, they're receiving biofeedback training, stress management training, where they learn that they can control muscles, okay, through biofeedback. And now there's been a recent article of technology-based hierarchy to assess low back pain and pain-related anxiety using the fear avoidance model. So a quote that I am very fond of is, fear of pain and what to do about it may be more disabling than pain itself. And this was from a Valen article that Waddell first introduced in the 1990s. Next slide. Okay, so everything I've spoken about are referenced. So I would highly recommend that you go through those references to find out more about what we were talking about today. So I guess we can take some questions now.
Okay, thank you very much, uh, Dr. Gatchel. We do have quite a lot of questions,
Okay.
and so we have questions from. Also, we have quite a mixed audience. We have patients and healthcare providers.
Mm-hmm.
And so I think at the time that the model came up, where you showed the model, um, one person said, I don't understand, does this apply to chronic pain? There is no injury involved. And then the perception was there's no recovering from fibromyalgia.
Mm-hmm. Well, fibromyalgia is, a very difficult type of pain disorder, but it can be treated, and one has to incorporate the fact that the patient will not be cured from the fibromyalgia. We have to get away from the traditional curative model. There is not a cure for many of the illnesses. There's only management. So you think about what used to be the traditional diseases like hypertension, diabetes, asthma. Can we cure those? No, we can only manage them. Okay? The same thing with fibromyalgia. It's an illness that in many ways cannot be cured. So the patient has to learn how to manage it. And part of that management is realizing that there will be exacerbations of pain, but they are taught how to cope when those exacerbations occur. They are basically taught how to decrease their fear avoidance, because the fear avoidance will create deconditioning, which will then make them more susceptible to the pain. Does that make sense?
Okay. It makes
Any
sense. It
follow-up
makes
to
sense
that?
to me, yes. There's a couple of questions together, and I'm going to tell them to you together because I think that your
Okay.
response will be. So the first is, what treatment interventions are most effective in overcoming fear avoidance in chronic pain clients? This was early on in your presentation before you started talking about the treatment.
Yeah.
And then what does the different cutoff severity scores mean in terms of recommendations for treatment interventions?
Yeah. Well, the most effective type of psychosocial intervention is cognitive behavior therapy. And that's been around a long time. It's been proven to be very effective. And this is where things like graded exposure or systematic desensitization can be used to gradually increase patients to more and more activity and teach them how to deal with that anxiety about pain occurring. Once again, in terms of the cutoff points, usually if it's severe or extreme, 61 and above, 61 to 100, that's when it's going to be a problem for patients. And that should be a highlight to the healthcare professional that we really need to get a handle on this fear avoidance in these patients. Moderate, keep an eye on it, but you might not have to deal with it unless you feel that they are regressing a bit. Usually the subclinical and mild levels will not experience many problems due to their fear avoidance. It's just a natural type of, they'll still have a tendency to approach exercising and functional restoration. Okay, so, but those are just broad cutoffs. But the top two are the ones that you can expect from our studies. You can expect those are the ones that even after treatment, they will show before treatment, they will show the greatest amount of anxiety, depression, fear, somatization, so on and so forth. But with treatment, we can decrease those levels. Okay.
Yeah. So is the FACS questionnaire available online or in the public domain?
Yeah, it's in the public domain. It was, again, in the references that are included. It was published in the journal Pain Practice in 2015, volume 16, pages 435 to 450.
And is it, now do you know, is that a public access article, or would you be able to provide a link to the instrument?
It's not public access, but if you're at an academic institution, you can probably download the article from that journal.
Okay, so for that purpose, what we are able to do is we're able to provide a link to the article and to the publisher for those that wish to publish it, wish to purchase it.
Yeah, and in that particular publication, in an appendix, the FACS questionnaire is included in the appendix.
Okay. I'm learning techniques to improve neuroplasticity. It has allowed me to judicially to increase my ability to increase my level of exercise. That's not really a question, more of a statement around neuroplasticity. What happens if the type of pain you have isn't caused by movement, but by being still, i.e. sitting, standing, and the individual is constantly moving? What would be your recommendation for this individual?
Well, I didn't get all of it. So a person who is sitting or...
So their pain is when they are static, not moving.
Yeah. Okay. That happens quite a bit. Okay. So what we have to teach them to do is maybe the way they're sitting is maladaptive. Okay. What are they sitting on? Is it the ergonomics of the chair they're on, or the couch they're on, or whatever? We know that a lot of people are, if they're sitting too long, they'll start experiencing pain. And so a lot of people now are in academia. You go by offices and people have their computers on a lectern so they can stand up and work, because sitting ergonomically creates too much strain on different parts of their body. Whereas standing, it doesn't create as much, okay, because you're not basically bending joints by sitting and whatnot. Some people that will have both. So when they get tired or start experiencing some pain by standing up, then they can go and sit down. And so ergonomically, that's probably the best strategy to use, because you're not putting undue pressure for a long time on any part of your body. So in terms of your butt, you're not getting much butt pain, or in your lower back. That can cause some problems, or your knees if you have some knee dysfunction. So the combination of two can be used. So yeah, by just doing nothing and just sitting, one can experience the pain.
I'm just going to do one more question, and then I will send other questions to Dr. Gatchel, and we'll create a Q&A for those that aren't answered. But I thought this one was it could be relevant to a number of people. It says, quite commonly, clients with chronic pain reside in rural areas and do not have access to chronic pain clinics. Are there components of your work where an online clinical counseling for clients has been investigated?
Good question. Unfortunately not, but it is a very important new area that people are looking into, and it sometimes is referred to as telemedicine or telepsychology, or in this case it might be functional restoration. So I think the technology has reached a point where one can provide that. There are, on iPhones, there are smart apps that you can click onto. So I think the technology is there, and I know a lot of people are starting to develop or utilize this technology for providing it, because the questioner was correct. People in rural areas away from major treatment centers, they're at a significant disadvantage because they do not have access to care. So the big push now is to get the care out to those areas. And I think in the next few years, you'll see more and more of that occurring.
Dr. Gatchel, I'd like to thank you so much again for your presentation, and I would like to thank all participants for joining us.